to later years of reproduction. Advanced age of childbearing has been related to socio-demographic factors such as increased rates of university education, employment, divorce rate, as well as remarriage. A significant rise in the first-time mothers of the age group of more than 35 years has shown a 44% in 1987 to 11% in 2005, and a corresponding decrease in the less than 25-year group. Fertility potential declines with advancing age due to the reduction in quality and quantity of follicular pool in the ovary, leading to reduced fertility and fecundity. Advanced age is the most significant risk factor for infertility and has higher risk of resulting in pregnancy loss, complications, and adverse pregnancy outcomes. Women should be made aware of by their healthcare providers of effects that advanced age has on their reproductive potential. There is also a decline in testicular function in men, and advanced paternal age is associated with an increased risk of spontaneous abortion and increase in frequency of some autosomal dominant conditions. Men of more than 40 years of age and their partners should be counseled on above for a more informed decision on timing of childbearing. Couples experiencing infertility between the age groups of 35 to 40 years should seek medical investigation in 6 months, and whereas couples in the age category of more than 40 years should seek medical investigation immediately. Consequences of delaying childbearing include increased risk of infertility, pregnancy and birth complications, and maternal and fetal morbidity and mortality. Ovulation is a physiological process defined by the rupture and release of the dominant follicle from the ovary into the fallopian tube, where it has a potential to become fertilized. The ovulation process is regulated by flux and gonadotropic hormones such as FSH and LH. And ovulation is the third phase within the large uterine cycle. Follicular release occurs around 14 days prior to menstruation in a cyclic pattern if the hypothalamic pituitary ovarian axis function is well regulated. The follicular release follows the follicular phase and precedes the luteal phase that progresses to either endometrial shearing or implantation. Here is just a diagram that depicts normal menstrual cycle from day 1 to 28, containing the follicular phase, ovulation, and the luteal phase. So the gonadotropin releasing hormone that is made and secreted by the hypothalamus stimulates the release of FSH and LH from the anterior pituitary gland through variations in the pulse frequency. So low frequency is for FSH secretion and high frequency for LH secretion. The process is regulated by a complex interplay of hormones, and the tight regulation and control changes between them is imperative for the development and release of an oocyte. So in the follicular phase, it starts on day 1 and ends with ovulation on day 14, where FSH stimulates the ovaries to produce the follicle. Excuse me. So FSH is secreted from the anterior pituitary gland in response to the slow frequency pulsatile GnRH. FSH now then stimulates the growth and maturation of the immature oocytes into the secondary follicles before ovulation. Surrounded by the granulosa cells surround this developing follicle, and there's an increase in the release or production of estrogen. So after 2 days of sustained elevated estrogen levels, the LH surge causes luteinization of the granulosa cells into LH receptive cells. And this transition enables the granulosa cells to respond to LH levels and produce progesterone. Estrogen produced by the granulosa cells of the developing follicle then exerts a negative feedback on the LH production in the early part of the menstrual cycle. But once the estrogen levels reach a critical level, as the oocyte matures within the ovary in preparation for ovulation, the estrogen then begins to exert a positive feedback on the LH production, leading to the LH surge through its effect on GnRH pulse frequency. So ovulation usually occurs on day 14, and surges of LH triggers the release of the mature egg from the dominant follicle, and this now enters the fallopian tube, where it can now potentially be fertilized. The LH is secreted from the anterior pituitary gland in response to the high-frequency GnRH release. And LH is responsible for inducing ovulation, preparation for fertilized oocyte uterine implantation and the ovarian production of progesterone through stimulation of the theca cells and luteinized granulosa cells. The alate surge creates an environment for follicular eruption by increasing the activity of the proteolytic enzyme that weakens the ovarian wall, allowing for the passage of the oocyte. After the oocyte is released, the follicular remnants are the theca and luteinized granulosa cells, and their function is now to basically produce progesterone, which is the hormone responsible for maintaining the uterine environment that can accept a fertilized embryo. The luteal phase is day 15 to 28, where we have a ruptured follicle that forms a corpus luteum. This secretes progesterone that assists with the endometrial thickening for possible implantation. And if fertilization occurs, the embryo will implant into the lining. If no fertilization occurs, the corpus luteum degenerates, leading to a drop in progesterone, and then we have menstruation. So the corpus luteum degeneration causes a drop in progesterone and the estrogen. With regards to infertility in advanced maternal age patients, it's usually due to ovulatory disorders and structural causes. In ovulatory dysfunction, there is a variety of hormonal factors that interfere with the complex sequence of hormonal events required to trigger ovulation. Problems can occur at any point in this pathway and can lead to failure of ovulation. Structural causes include chronic PID, severe endometriosis, fibroids and polyps, among others. Ovarian aging, the rate of oocyte loss is similar throughout female reproduction phase and remains consistent until the onset of menopause, indicating that the loss of oocytes persists until ovarian function comes to a complete standstill. When women experience infertility, sterility, cycle shortening, menstrual irregularities, and menopause, it's noted that 1 to 2% of women experience premature ovarian failure or menopause before the 40 years of age. And loss of ovarian function is not pathologic, but rather an inevitable sequence of aging and is ultimately unavoidable. So we see a decrease in the number of follicles, meaning that there's a decrease in the follicular cohort itself. There's a decrease in inhibin B production from the granulosa cells in early follicular phase, and follicle stimulation hormone increases due to the lack of the negative feedback by inhibin B. This is one of the earliest signs of ovarian aging. Clinical signs of ovarian aging include, like I mentioned, menstrual irregularities, where we have the cells cycle shortening, and this is generally due to the shorter follicular phase itself. Oocyte quality is also affected by age, and aneuploidy increases in elderly women. There's a 10% chance in the less than 35-year group, 30% in 40-year group, 40% at 43 years, and more than 45-year-olds have showed 100% of aneuploidy. Decrease in quality of oocyte may be in the formation and function of the meiotic spindles. So they might appear more diffuse in the aging oocytes. And the diffuse formation and functioning of these spindles basically are not tightly arranged, which leads to the meiotic division errors. Annual ovulation in older females. So basically the ovary does not release an oocyte during the menstrual cycle, leading to an absence of ovulation. In older women, this could be due to age-related decline in ovarian function or hormonal imbalances. As women age, the number and quality of oocytes decrease, leading to the irregular ovulation or anovulation. And with regards to the hormonal imbalances, age can reduce levels of estradiol or progesterone, and elevated levels of FSH is noted. FSH levels increase in older women experiencing infertility, and this is primarily due to a decline in ovarian function and a decrease in the quantity and quality of follicles. This is from a hormonal feedback mechanism, where there's reduced estrogen production due to the ovarian follicles produce estrogen, which provides negative feedback to the hypothalamus and pituitary gland to release FSH, to regulate FSH levels. As the number of follicles decline and their function diminishes, the amount of estrogen decreases. So the hypothalamus and pituitary gland respond to the lower levels of estrogen by increasing the production and release of FSH in the attempt to stimulate the ovaries to produce more follicles. This increased production of FSH is an attempt to compensate for the reduced ovarian response and maintain normal menstrual cycles and ovulation. We note a decrease in the antral follicle count and development in older females as well, and this is because of follicular depletion. We know that females are born with the infinite number of primordial follicles, which decrease progressively over time due to natural atresia. From the age 30 to menopause, the number of remaining follicles is significantly reduced, leading to a low AFC. A decrease in AFC is a key factor contributing to infertility in older women. And AFC decreases with age, resulting in ovarian reserve diminishes, which means reduced fertility potential. There is also a decrease in endometrial receptivity. Women who experience infertility show reduced endometrial receptivity. This refers to the ability of the endometrium to allow embryo implantation, which is crucial for a successful pregnancy. Factors contributing to this are, again, hormone changes, endometrial aging, and chronic inflammation and scarring. So hormonal changes, we have a decline in the reproductive hormones, the estrogen and progesterone, that generally prepares the endometrium for implantation. And then aging of the endometrium alone, the changes with age that affect the structure and function of the endometrium. And cellular aging of the endometrium can also result in a less favorable environment for implantation. Chronic inflammation and scarring occurs in patients who have a history of conditions such as endometriosis, fibroids, or previous endometrial surgery. These conditions can disrupt the normal architecture of the endometrium and reduce its receptivity. Blood flow and vascularity is also important. So adequate blood flow to the endometrium is crucial for its development and function. So age-related vascular changes can reduce blood flow, impacting endometrial growth and receptivity. On a molecular and genetic level, age-related changes in the molecular level can impair the endometrium's ability to respond to hormonal signals. So changes in the expression of implantation-related genes and proteins can affect the window of implantation. So at present, ultrasound imaging and expression of related biochemical markers in endometrium have been used to assess endometrial receptivity. Transvaginal ultrasound is the first-line method for assessment of the follicular development and the endometrial growth. And 7 to 14 millimeters is considered optimal. The parameters we look at is the endometrial thickness, classification, and the blood flow. There was a study that we came across on fecundity disorders in older women by Li Wang et al. And they concluded that ovulation rates in older women is 68 compared to 82% in younger women. AFC and development, endometrial hypersensitivity, and AMH levels are all reduced when compared to their younger counterparts. And FSH levels are actually increased in older women. It was noted that the AFC, the average diameter of the dominant follicle on day 12, 14, 16, and 18 was actually smaller than the younger counterparts. And the subendometrial region resistance index on day 12, 14, 16, 18 was higher. It was noted that the vascularization index and flow index and vascularization flow index were lower in the older female. Vascularization index and flow index have been shown to be the best parameter for predicting endometrial receptivity in older women during the implantation window, with a sensitivity of 92.6% and a specificity of 85.4%. The antimalarial hormone and AFC are superior to the menstrual cycle and FSH in the evaluation of ovarian function in older women. And AMH is an excellent predictor to oocyte yield. The AFC has shown to be a good indicator for ovarian function, as per the study. So assessment of ovarian aging is done with ovarian reserve testing, which has become very important in assessing ovarian age. It is part of the routine fertility workup and is a good predictor of ovarian response to stimulation. The parameters include chronological age, antimalarial hormone, follicular stimulating hormone, estradiol, and the antifollicle count. Other parameters can include estimation of inhibin levels, ovarian volume, and chromophene challenge test. Excuse me. The AMH is a key indicator used in ovarian reserve assessment. The levels can be measured at any time during the menstrual cycle as they're relatively stable. High levels are noted to be more than 3 nanograms per ml, suggestive of high ovarian reserves, and indicates a large number of antral follicles, and it's usually commonly seen in patients with PCOS. Normal levels are between 1 and 3 nanograms per ml, indicative of a normal ovarian reserve and suggests a good number of eggs and favorable fertility potential. Low levels are less than 1. This indicates a diminished ovarian reserve, suggesting a low number of remaining eggs. And very low is less than 0.5. Significantly diminished ovarian reserve is noted and suggests very few remaining eggs. This is often associated with advanced reproductive age or premature ovarian failure. AFC is a measure of number of small follicles, which range between 2 to 10 millimeters in diameter in the ovaries, and is visible on the ultrasound during the early follicular phase of the menstrual cycle, typically between days 2 and 4. It is a key indicator of ovarian reserve, reflecting the remaining quantity of the variable eggs in the ovary. A higher AFC generally correlates with higher success rates in fertility treatment, while lower may indicate the need for more intensive interventions. A normal AFC ranges from 10 to 20 follicles. A higher count typically have better fertility potential, and the lower indicate diminished ovarian reserves. So high values are more than 20. Can also be seen in PCOS. Normal is between 10 and 20, indicating a good ovarian reserve, and low is less than 10 follicles, showing a diminished ovarian reserve. FSH levels are typically measured on the 2nd or 3rd day of the menstrual cycle, when they are most indicative of ovarian reserve. Interpretation of these values: the normal FSH is less than 10, indicating a normal ovarian reserve and function. Borderline elevated is between 10 and 15, suggests a possible decrease in ovarian reserve. And high is greater than 15, indicating diminished ovarian reserve or reduced fertility potential. So estradiol is ovarian function and hormonal environment is necessary for follicular development and maturation. So this is also done between day 2 to 4 of the menstrual cycle, along with FSH levels. The timing helps to provide a clear picture on the baseline hormonal environment and ovarian function. Normal levels are less than 50 picograms per ml, indicating a normal ovarian function in a healthy hormonal environment, and suggest that FSH levels are not being suppressed by high estradiol levels, providing a more accurate assessment of ovarian reserve. Borderline levels are between 50 to 80 picograms per ml and indicates slightly increased ovarian activity or early follicular development, and can still be considered within the normal range, but may warrant close monitoring in conjunction with FSH levels. High levels are more than 80, and elevated estradiol levels during the early follicular phase can suppress FSH levels, potentially masking and elevating FSH that indicates diminished ovarian reserve. High estradiol levels can result from functional ovarian cyst, residual follicular activity, or exogenous hormonal use. Assessment of ovarian reserve can predict ovarian response to fertility treatments such as IVF. And the antral follicle count and AMH are useful in prediction of the poor ovarian response with IVF. So ORT is usually offered to women of 35 years and below with risk factors. So that the risk factors include single ovaries, a single ovary, previous ovarian surgery, poor response to ovarian stimulation, poor response to FSH, exposure to chemotherapy or radiation, or unexplained infertility. With regards to the structural disorders, having inflammatory disease chronic, which is caused by chlamydia and Neisseria gonorrhea and other bacteria, can also contribute to PID. This basically affects the reproductive organs, causing inflammation and infection of the endometrium, fallopian tube, and the ovaries. So the inflammation and immune response lead to swelling, redness, and the influx of immune cells to the affected area, and they cause significant damage to the reproductive organs. Tissue damage and scarring, if persists or severe inflammation occurs, can lead to the formation of fibrosis and adhesions. And in the fallopian tubes, this can lead to partial or complete blockage, distortion of the normal architecture, and impairment of its function. So the impact that PID has on fertility is tubal damage and blockage by the scarring and the adhesions itself. And there is basically the transport of the fertilized egg to the uterus, or the passageway for the sperm also gets affected. Ectopic pregnancy is in high incidence due to the damage of the tubal structure itself, and is impaired tubal function, like we said, for the blockage and impairment from the cilia within the tubes that get damaged. And this impairs can lower the chance of successful fertilization and transportation of the fertilized egg. Chronic pelvic pain can occur because of chronic inflammation and scarring from the PID that can lead to ongoing effects, affects the sexual function and quality of life, which also can complicate the fertility treatments. Endometrial damage, endometriosis, inflammation of the uterine lining can also interfere with implantation, and chronic endometriosis can lead to a less receptive endometrium, reducing successful implantation and pregnancy. So, tuboplasty versus IVF. Tuboplasty is given to mild to moderate tubal disease and in younger female, whereas IVF is given for extensive pelvic adhesions in the older age female, and when it's impossible for tubal reconstruction due to the absence of tubes or history of tuberculosis, appendicitis, or failed tubal surgery, or existence of other infertility factors. The success rates of IVF in the less than 35-year group showed a 40 to 50% per cycle. Between the 35 and 37-year group, it was 30 to 40%. The 40 to 42-year was 10 to 20%, and more than 42-year-olds showed less than 5% success rate. With donor eggs, there was a 50% success rate or more noted, regardless of the age. With tuboplasty in the less than 35-year group, it was a 40 to 60% success rate. 35 to 40-year group showed a 20 to 40% success rate, and the more than 40% had a 20% success rate. So with the endometriosis, the inflammation causes damage to the ovaries, fallopian tubes, and other reproductive organs, impairing its function. The scarring tissue and adhesions lead to the formation of scar tissue, fibrosis, and adhesions and distortion of pelvic anatomy, and this obstructs the fallopian tubes as well. The ovarian function, basically endometriomas compromise ovarian reserve and reduce the quality and quantity of eggs. The hormonal environment, endometriosis can disrupt the hormonal environment necessary for ovulation, fertilization, and implantation. Medical treatment that can be, sorry about that. Medical treatment, we have hormonal therapies, GnRH agonists, progestins, aromatase inhibitors, and your non-hormonal medications include NSAIDs. Surgical therapy, well, laparoscopy is considered the gold standard for diagnosis and treating of endometriosis and has shown to be able to improve fertility between 30 to 70%. Laparotomy is used for more, is an option for more extensive, extensive open surgical procedure and is used for severe cases of endometriosis, where laparoscopic surgery is not feasible. With assisted reproductive technology, IVF is often recommended for women with endometriosis, especially if other treatment has failed or there is severe damage to the reproductive organs. IVF basically bypasses many of the barriers to conception caused by endometriosis, such as the blocked fallopian tubes. Ovulation induction and intrauterine insemination may be considered for women with mild endometriosis. And success rates of OT in the less than 35-year group was 40 to 50% per cycle. In the 35 to 70-year group, it was 30 to 40%. In the 38 to 40-year-old, it was 20 to 30%, and the more than 40-year-old was less than 20%. So fibroids and polyps. So the impact that it has on infertility is the fact that it distorts the uterine cavity. It can cause blockage of fallopian tubes based on the size of it and the position, and it blocks blood flow as well. The alteration of the blood flow to the uterine lining, impacting the ability to support the implantation in early pregnancy. And the hormonal environment basically interferes with ovulation and implantation as well. The hormonal therapies are more or less the same with regards to the GnRH agonists. We can use progesterone release intrauterine devices, oral contraceptives, or progestin. Non-hormonal medication includes tranexamic acid and NSAIDs. These are just to help the symptoms. Surgical treatments include myomectomy, uterine artery embolization, focused ultrasound surgery, where it's a non-invasive technique using MRI-guided high-frequency ultrasound waves to destroy the fibroids itself, but its impact on fertility needs further research. Hysterectomy, this is a definitive solution for fibroids, but obviously eliminates the possibility of pregnancy. With assisted reproductive technologies, IVF can be considered, but not when there's distortion of the uterine cavity or after fibroids, but not distort the uterine cavity or after fibroids have been surgically removed. Egg donation for older women with reduced ovarian reserve, combining egg donation with fibroid treatment can actually improve the chances of the pregnancy itself. So in summary, the declining birth rate and reduction of fertility production occurs in women starts at 35 years of age. Ovarian aging is the primary cause of age-related infertility due to the diminished follicular count. Uterine endometrium retains normal capacity for implantation throughout a woman's reproductive age. And the rise in both primary and secondary fertility, as well as high rates of pregnancy loss by older women, has driven the increased demand of fertility services. Decline in fertility may get accelerated by gynecological conditions itself or by the therapy required, or both. Patients with previous ovarian surgery, strong smoking history, family history of early menopause, Turner syndrome, mosaic and Fragile X mutation are all at risk of accelerated fertility decline. Advances in fertility science opened increased options for fertility treatments and art. It has been observed in donor insemination that younger women conceive quickly and more frequently than their older counterparts. A study of 3,000 cycles showed that women below 30 years of age had a cumulative pregnancy rate of 62% compared to 44% in women in their 30s or more than 30-year-old in women. Women in more than 30 years of age, pregnancy was noted to be achieved quicker with multiple or more cycles of treatment. The pregnancy rate with artificial reproductive therapy shows a significant impact of female age on success. And while age is the most important prognostic factor of IVF. So with regards to the treatment of age-related infertility, the aim is to increase monthly fecundity and decrease the time to conception. So if there's short time of infertility, natural conception may be undertaken. It's important to implement lifestyle modifications, maintaining healthy weight, regular exercise, manage stress through relaxation techniques. And medication, ovulation induction agents like clomiphene citrate, letrozole, or metformin can also be used in women with insulin resistance or PCOS to improve ovulation. With gonadotropins, we use injectable hormones, FSH and LH, to directly stimulate the ovaries to produce multiple follicles. The success rate of Clomid with ovulation is approximately 70 to 80% of women will ovulate with clomiphene, and pregnancy will occur in about 10 to 12 per cycle, with cumulative pregnancy rates of around 30 to 40 over 6 cycles. For letrozole, ovulation is similar to clomiphene citrate with about 70 to 80% of women ovulating, but the pregnancy rates are higher compared to clomiphene in some studies. With PCOS, pregnancy rates can be found in 15 to 25% per cycle. With gonadotropins, ovulation occurs in nearly 100% of women, and approximately 15 to 20% of pregnancy rate is noted per cycle, with higher risk of multiple pregnancies. Metformin, metformin induces ovulation about 30 to 50% of women with PCOS. And when combined with clomiphene, the ovulation rates can be significantly improved compared to use of clomiphene. So combine the treatments, clomiphene and the metformin, when used together, it can be more effective, especially in women in PCOS who don't respond to clomiphene alone. And letrozole and gonadotropins, letrozole will be used to prime the ovaries before starting the gonadotropins, potentially improving outcomes and reducing the amount of gonadotropin needed. Endometrial receptivity treatment is generally hormonal with estrogen and progesterone supplementation. Optimizing the blood flow, low-dose aspirin or other medication may be used to improve blood flow to the endometrium. And personalized embryo transfer. This is based on receptivity testing. And the type of embryo transfer can be personalized to align with the patient's specific window of implantation, improving the chances of successful implantation. Treatments like granular cell colony stimulation factors infusion or PRP therapy are being investigated currently to improve endometrial thickness and receptivity. Other methods of ART is ovarian stimulation. Well, we spoke about that, and gonadotropin addition to it. We have control ovarian hyperstimulation, and this can be followed by intrauterine insemination. There is the pre-malignant genetic testing for aneuploidy, which unfortunately has revealed an alarming high rate of aneuploidy in almost 60% of cycles. And these 60% of cycles end with no embryo available for transfer after the PGTA testing in advanced maternal age patients. So IVF and embryo transfer can be used, and adjuvants include the addition of androgens to improve the oocyte quality itself. With declining egg quality, is oocyte donations and IVF can be an option, and ovulation stimulation is the oral stimulation agent and the IUI that showed a 7% success rate in the age group of 34 to 40, 4% in the 41 to 42 group, 2% in the more than 42-year-old. With gonadotropins and IUI, 6% between the age of 38 and 40, and 2% of the more than 42-year age group. Elderly females should consider at least 2 cycles of the ovarian stimulation if IUI is used as the first-line therapy, but shift to IVF needs to be done as soon as it's been unsuccessful in the first few cycles. So IVF and ovarian stimulation offers higher pregnancy and live birth rates compared to ovarian stimulation and the IUI, being 11.4% in the 40-year group of live birth rates and 2% live birth rate in the more than 42-year-old. So above rate decreases with the ovum donation. So third-party reproduction options include IVF and the ovum donation. Pregnancy rate is related to the age of the donor but not the recipient. So menopausal age is the maximum age for offering this option. Embryo donation is used and accepted method in male infertility-related factor cases. Surrogacy is another technique that circumvents the problems of the uterus as well as ovarian reserve. This is usually with or without ovum donation. The other techniques, which are still experimental with high failure rates and side effects, but they do hold promise for the future, include ovarian tissues cryopreservation and reimplantation, ovarian rejuvenation with stem cells taken from autologous ovarian cortex, the oocyte augments procedure, mitochondrial transfer, regeneration of the endometrium from bone marrow stem cells or PRP, and uterine transplant itself. Artificial extension of fertile lifespan due to technology. So this is generally the oocyte cryopreservation or embryo cryopreservation. There's a shift that's noted from slow freezing method to vitrification. This has shown to improve oocyte survival rates, fertilization rates, and pregnancy rates. The post-thaw survival rates using vitrification is as high as 96.9%. So basically, oocyte freezing is now accepted as a standard and successful procedure, ensuring almost 80% of oocyte survival capable of producing healthy embryos and live births. This technology has created scope for women delaying childbirth for various medical and social reasons and still have their own biological child. So vitrification is the ultra-fast cooling method using high concentration of cryoprotectants This method basically solidifies the oocyte into a glass-like state and minimizes crystal formation. The oocyte is vulnerable to damage from the ice crystal formation due to its high water content and its sensitive meiotic spindle apparatus. So petrification basically bypasses that. Indication for oocyte cryopreservation is a prevention method for age-related fertility decline. It's given to women at risk for age-related fertility decline, women diagnosed with malignant disease requiring therapy, women undergoing female to male gender transition who might require pregnancy later on in life, and couples who aren't able to produce sperm at the time of oocyte retrieval. The appropriate age for oocyte cryopreservation, well, studies have revealed it's average between 36 to 38. Women are only actually seeking fertility preservation techniques later on in life, hence the average age of 36 to 38. And the risk is in less than one major complication just noted, which is the ovarian hyperstimulation syndrome, which is the most common. So maternal age-related risk in conception include chromosomal aneuploidy. It's the most commonly discovered abnormality. And the estimate is that most oocytes are aneuploid after 40 years of age. The incidence of this chromosomal abnormalities in art compared to natural conception has shown similar rates. So the risk of chromosomal abnormalities increase with advanced maternal age, but decrease with advanced gestational age. Trisomy 21 is 1 per 68 at age 40. Trisomy 13 and 18 is less common at 1 per 495, and 1 by 157 respectively at 40 years. Sex chromosome abnormalities show an increase with maternal age as compared to trisomy 21. Turner syndrome and other sex chromosomal abnormalities and triploidy are not influenced by age. They don't occur due to the maternal meiotic non-dysfunction. So fortunately, effective screening for chromosomal abnormalities does exist for women concerned about these risks. We have the use of maternal age-related risk for fetal aneuploidy, combined with the assessment of nuchal thickness measurements and maternal serum beta-human chorionic gonadotrophin levels, as well as pregnancy-associated plasma protein A levels. Above, combined with the fetal heart rate, has a detection rate of 90% for trisomy 21, 97 for trisomy 18, 92% for trisomy 13, and has a false predictive rate of 4%. With sulfate DNA testing, this provides an improvement in detection of the most common chromosomal abnormalities, with a detection rate of 99.7% for trisomy 21, 97.9% for trisomy 18, and 99% for trisomy 13, with a false predictive rate of 0.04% for each trisomy itself. Counseling of an advanced maternal age mother about her pregnancy-specific risks include first trimester ultrasounds. Women with high risk based on ultrasound findings should be offered diagnostic invasive testing, and obviously fetal medicine specialist discussion. The effect of advanced maternal age on genetic abnormalities, other than clinical areas of art, is still not well known, but epidemiological studies suggest that there is a correlation between autism and advanced maternal age as well as advanced maternal age. But here, more studies are required to understand this association. Congenital malformation, the risk of non-chromosomal birth defects increases with advanced maternal age, and the incidence of structurally malformed infants increases with advanced maternal age. Overall, the additional age-related risk for non-chromosomal malformation is 1% in women more than 35 years of age. So historically, advanced maternal age has been defined as being over 35 years of age. Definition of very AMA, according to Fitzpatrick et al., is pregnant woman is defined as being over 48 years of age. Whether or not maternal age is considered to be advanced is affected also by the sociological, ethnic, and cultural considerations. And it is difficult to define a specific age threshold for pregnancy outcome, increasing age, and its effect on pregnancy, which occur as a continuum. A UN report in 2015 showed that the mean age of childbirth worldwide declined from 29.1 years in 1950 to 1955 to 27.5 years in 1990 to 1995. Then there was a rise that occurred in the past 3 decades to 29.4. The mean age of first childbirth was 23 to 25 years in the 1970s, that increased to 27 to 29 years in 2017. Another CDC report showed a decrease in proportions of first births to women less than 20 years of age, and an increase in rate of births for women more than 35 years, with a prevalence of more in the 35-year group of 7.5% in 2009 and a 23% rise in 2019. And these births or pregnancies account for 9.1% of all pregnancies. In the 45 to 49-year group, there was a 0.39 per thousand deliveries in 1970, which increased to a 1.79 per thousand deliveries in 2010. So another US report showed that there was a increase by 4% in the 25 to 29-year group. Between the 30 to 34-year group, there was an 18% increase in delivery. 35 to 39-year group showed a 5%. The 40 to 44-year group showed an 8%, and the 45 to 54-year-old group showed a 26% increase in delivery rates. To summarize the impact of maternal age on pregnancy outcomes, in early pregnancy complications include the risk of ectopic pregnancy, spontaneous birth, pregnancy involving multiple gestation, chromosomal aberrations, and birth defects. In late pregnancy, there's increases for hypertension and preeclampsia, pre-gestational and gestational diabetes, and placenta previa, as well as low birth weight and preterm deliveries, risk of stillbirth, increased cesarean section rates, and postpartum, there's an increased risk for postpartum fever, postpartum hemorrhage, thrombosis, and hysterectomy. So impact in late pregnancy and complications, there's association with great risk of major obstetric complications, which includes increase in maternal mortality, prevalence of severe morbidities, and placental abnormalities. A CDC report showed a gradual increase in maternal mortality rate from being 10.8 per 100,000 births in the less than 35-year age group and 38 per 100,000 births in the more than 35-year age group. Women of more than 35 years of age are in the 2 to 4-fold higher risk of having hypertension compared to women in the 30 to 34 years of age group. Hypertension and other core factors may lead to an increased incidence of preeclampsia, which is usually 3 to 4% in the general population, and 5 to 10% in women of more than 40 years of age, and 35% in women more than 50 years of age. So basically, there's an increased risk in the 40-year group, and advanced maternal age risk is the same as being a nulliparous, though it's less than the risk compared to increased BMI of more than 30 to type 2 diabetes and chronic hypertensive patients. So high-risk women can be offered aspirin prophylaxis of 150 milligrams as per Aspartel, and dramatically reduces the rate of preterm delivery of less than 34 weeks delivery or preeclampsia by 80%. The incidence of pre-gestational and gestational diabetes is 3 to 6-fold higher in the 40-year group, it's 3.6% in the general population, and 7 to 12% in the women more than 40 years. So older gravidas have an increased risk of abruptio and placenta previa. There's a 10-fold risk increase noted in the more than 40-year-old group, but the absolute risk is low, being 0.25%. Complications during labor and delivery, there is an increase in the cesarean delivery rate. After a study run between 2003 to 2012, showed that the age group between 25 to 34, there was a 20% increase. In the 45 to 49-year group, there was a 36% increase, and the 50-year group showed a 61% increase. Some authors explain that the labels of advanced maternal age and high risk affect the physician's preference for the mode of delivery. So there also has been a reported increase in the labor dystocia with advanced maternal age, irrespective of parity. So indications can include being an elective Caesar, on maternal request, physician's discretion, or second stage labor implications. The relative safety and perceived advantage of low-risk Caesar drives widespread acceptance for non-medical and non-obstetric indications. So a study compared outcomes of women with planned Caesar delivery versus women with vaginal delivery, and the outcome was that the planned Caesar group had higher mortality outcome compared to the vaginal delivery group, and they had a higher risk of complications in the Caesar group itself. So prenatal morbidity and mortality with advanced maternal age. There's low birth weight. There's a 1.9-fold higher risk in women between the age of 35 to 50 compared to the women in the 20 to 24 year group. Preterm delivery of less than 32 weeks, there's a 1.7-fold increased risk. 33 to 36 is a 1.2-fold increased risk. And stillbirths are most prominent at 37 weeks, but at 39 weeks, an advanced maternal age mother, being between the 40 to 44 year group, has a risk of stillbirth, while her risk of stillbirth is equivalent to the risk at 42 weeks in a 25 to 29-year-old patient. Postpartum complications of advanced maternal age. These include postpartum hemorrhage, fever, need for blood transfusion, prolonged hospital stay, high incidence of ICU or high care admission, thrombosis and hysterectomy, amniotic fluid embolism and obstetric shock, or peripartum cardiomyopathy. The long-term complications, well, there's effect on maternal longevity. Age-adjusted mortality rates started from 55 years of age, noted to be higher for childless women. And there's a decrease in parents women with an increased age at the last birth, meaning more than 45 years at the last delivery. So Jaffe et al. Said, proved that the parity has more influence on longevity than the late age. And impact of advanced maternal age at first delivery on longevity is unclear. So delayed first pregnancy is a risk factor for breast cancer, and it increases your risk for hemorrhagic stroke in women who had delivered their last pregnancy or more than 40 years old. Preeclampsia is a risk factor for cardiovascular disease. Postpartum depression is relatively common as a long-term complication. There was a group of studies conducted in Taiwan that reported that the younger age and parity at first delivery may actually provide you with a protective effect on the risk of death from brain cancer, colon cancer, and chronic liver failure. But many studies are still undergoing to investigate the long-term risks currently. So recommendations of pregnancy management in elderly women. Preconception is essential to manage and control the chronic diseases with advice on health, diet, regular exercise, treat and adapt treatment for pregnancy itself, screening of the high-risk population for diabetes, screening of micro and macrovascular complications. In the first trimester, we consider the artificial reproductive therapy, ectopic pregnancy, exclusion, chromosomal abnormalities, and congenital anomalies. So we try to limit the multiple pregnancy, make sure we do an early ultrasound to determine the location, non-invasive screening, ultrasound for detecting again the fetal anomalies, and then if there is anything, then for invasive screening thereafter. In the second trimester, we look at gestational diabetes, hypertension, location of the placenta itself, monitoring of fetal growth. So we screen for the diabetes, screen for hypertension and proteinuria. We make sure we find the placental location. We do estimated fetal weights at 32, 34, and 36 weeks, respectively. With the third trimester, there is a risk of stillbirth. We have to decide on the mode of delivery. And we have to make sure we avoid postpartum hemorrhage. So we can consider induction of labor at 39 weeks, manage the third stage actively, and to avoid postpartum hemorrhage. So we treat them as high risk, review every 4 weeks until 34 weeks, and then 2 weekly until 40 weeks. And in summary, basically biomedical screening, and if it's positive in trimester 1, then we can do chronic life sampling. In trimester 2, biochemical screening, non-invasive testing like the NT scans, and then invasive testings if required with amniocentesis itself. So with regards to timing and mode of delivery, Decisions around timing and delivery of a woman of advanced maternal age must be made with a balance between risk of prolongation of the pregnancy and risk of iatrogenic harm from timed delivery for both mother and the baby. So current data suggests that delivery at 39 weeks gestation is optimal to avoid morbidity related to early term birth and reduces the risk of antepartum stillbirth post-term. 39 weeks also provides optimal balance between the risk of respiratory morbidity and stillbirth risk, but this is only if there are no comorbidities or other obstetric considerations, then we should, indication, then we should consider delivery at 38 weeks in instances of diabetes and hypertension for patients with, Women of advanced maternal age have a small age-related elevated risk for term stillbirths. So induction labor at 39 weeks does not increase the risk of emergency C-section delivery and has no short-term adverse effects on mother or baby. Advanced maternal age women have high background of C-section delivery, and some of the risks that follow vaginal birth are also elevated in advanced maternal age. This would be balanced. This should be balanced with the apparent risk of serious maternal morbidity as a result of Caesar delivery. So hence, Caesar is not advocated for an advanced maternal age as a primary delivery option with no obstetric indication itself. In conclusion, the strength of the published evidence should compel medical professionals to increase educational efforts directed at alerting women to the danger of delayed childbearing. What is required is a true preventive method approach that begins with frank discussions about the biology of female reproduction and how age profoundly affects it. The topic needs to be introduced early in life, perhaps at the time that discussions regarding menstruation and pregnancy occur. Aging should not be represented as an undesired endpoint or as pathologic. Negative approaches create fear and the illusion that medicine can cure the problem. Counseling of complications of delayed reproduction is important because patients are full of denial when they seek advice on reproduction. They see themselves as older, but not too old. They see themselves as agile, but still fit, overweight, but not obese, borderline hypertensive, but not hypertensive. So frank discussion on all these problems might be encountered when considering pregnancy. So in the era of managed care, most physicians have about 5 to 10 minutes to discuss any and all of the issues above, and thus they choose to forego the discussion and simply refer to a specialist. Improved access and affordable options must be considered because in our time of age, medical aid covers the cost of investigation for infertility, but not the actual fertility treatment itself. So it is paradoxical that physicians should be able to identify a problem, but not be able to introduce a remedy to confront it. Thank you.
Okay. Thank you, Dr. Maharaj. This was a long topic. We managed to squeeze it together in 1 hour. So on that note, we'll take comments and constructive criticism. Okay, let's start with the floor audience.
Dr. Balashia and Dr. Maharaj. Good morning, thanks. Thanks for the talk, quite extensive and well covered. The part I couldn't clarify is the association you mentioned on PPH and advanced maternal age. Is this an independent association of age and the outcome, or is it because of the background morbidities that may be there, things like abruption or APH of whatever form, or maybe fibroids? And so has there been any evidence to say age alone is associated with PPH?
Yes, Prophet. Actually, the studies and the articles that we've gone through say that it's an independent factor of PPH itself. Even though the relative risk of having like placental abnormalities in regards to the location itself is low. So I think it has to do with the endometrial process itself of, developing the pregnancy, from my understanding, and sustaining it.
Okay.
On that note, thank you everyone for coming. Enjoy your long weekend.